Most people assume that when memory starts slipping after 60, it means the brain is aging. I assumed the same thing when I finished my fellowship, until I spent 14 years sitting across from patients who had been told exactly that. It's just aging, it's normal, while they were taking medications that were actively accelerating the destruction of their cognitive function, not slowing it, accelerating it. I had a patient, I'll tell you about her in a few minutes, who came to me at 73, already diagnosed with early Alzheimer's by 2 other physicians. And what nobody had done, not once in 2 years of evaluation, was look at what was in her medicine cabinet. What I'm about to explain may change forever how you think about your medications after 60. My name is Jennifer Hartley. I'm a board-certified neurologist with a subspecialty in geriatric neurology, what we call neurogeriatrics. I've spent over 14 years doing one thing, evaluating and treating cognitive decline in adults over 60 across outpatient memory clinics and academic medical centers throughout the United States. I've administered thousands of cognitive assessments. I've interpreted hundreds of brain MRIs in older adults. And I've sat with families at the moment they first heard the words mild cognitive impairment or early Alzheimer's, words that are sometimes wrong. Here is what most doctors don't explain, because they have 12 minutes per appointment. The brain at 70 is not a slower version of the brain at 50. It is a fundamentally different neurological environment. Blood flow is altered. The glymphatic system operates less efficiently, and the blood-brain barrier becomes increasingly permeable with age. A drug that is completely safe for a 45-year-old can be profoundly damaging in a brain over 60. The question nobody is asking is, what does this molecule do specifically to an aging brain? The brain runs on a neurotransmitter called acetylcholine. Think of it as the electrical current running through your memory circuits, essential for encoding new memories, retrieving old ones, and processing speed. Acetylcholine production in the hippocampus declines naturally between 30 and 45% from age 60 to age 80, according to data published in Neurobiology of Aging. Think of your brain's cholinergic system like a river. In a healthy young brain, that river flows strong. After 60, it is already running lower. It has less current, less force. 9 of the most commonly used medications in America work by blocking acetylcholine. They are called anticholinergic drugs. When you take one, a sleep aid, an allergy pill, a bladder medication, an antidepressant, you are throwing a dam across a river that was already running low. It's not X, it's not Y, it's Z. It's not the diagnosis of dementia destroying the memory of millions of older adults. It's not inevitable brain aging. It's a drug class that every physician knows can affect cognition, and that very few primary care doctors systematically review in patients over 60. A 2019 study in JAMA Internal Medicine, following over 284,000 patients aged 55 and older, found that higher cumulative anticholinergic medication use was significantly associated with increased dementia risk. The hidden villain here has a name: anticholinergic burden, and it is the first thing I check on every patient who walks into my memory clinic. Before I go further, I need to be very clear, because when we're talking about the brain, the details matter more than in almost any other area of medicine. If you are experiencing sudden severe confusion, inability to recognize close family members, a sudden headache unlike any you've had before, or sudden loss of balance, stop this video and go to the emergency room today. Those are neurological emergencies, and they are not what I'm discussing here. If your situation looks like one of those, this video is not for you. But if you are experiencing gradual word-finding difficulty, increasing forgetfulness for names and recent events, mental fog that seems worse since starting a new medication, and you are currently taking drugs for sleep, allergies, bladder urgency, anxiety, or depression, keep watching. This was made precisely with you in mind. I want to tell you about Margaret. She came to my clinic at 73. Retired school teacher, sharp, precise woman who had graded papers for 31 years and never misspelled a word. Her daughter brought her in because she had gotten lost driving home from the grocery store, a route she had driven for 18 years. By the time I saw her, 2 neurologists had already diagnosed her with early Alzheimer's. She had been on Aricept for 7 months. She was getting worse. When I did a comprehensive medication review, here is what I found. She was taking Diphenhydramine, the active ingredient in Benadryl. every single night for nearly 4 years. She was taking Oxybutynin for bladder urgency. She had been prescribed amitriptyline for nerve pain, and she was taking Hydroxyzine for anxiety. 4 medications, all 4 on the Beers criteria, all 4 blocking the same neurotransmitter system. I asked her, "Margaret, when did your memory problems start?" She thought carefully and said, "About 6 months after Bill died, when I started having trouble sleeping." That was the pivot. That unlocked the entire picture. It's not X. It's not Y. It's Z. It was not Alzheimer's. It was not irreversible neurodegeneration. It was 4 medications, prescribed by 4 different physicians, none of whom had seen the full list. With careful supervised tapering over 4 months, we removed 3 of the 4 medications. The last time Margaret came to my clinic, she came alone. She drove herself. She handed me a handwritten list, the names of every student from her first year of teaching. 37 names, she said. They came back. I thought they were gone forever. I had to look away for a moment. Has your doctor ever told you that your memory problems are just normal aging for your age? Write that in the comments right now. I want to know how many of you have heard those exact words, because in 14 years, I have heard patients repeat them to me more times than I can count. Now let's go through the 9 medication categories I see causing the most cognitive damage in adults over 60. Number 1, Diphenhydramine. This is the active ingredient in Benadryl, ZzzQuil, Unisum sleep tabs, and most over-the-counter sleep and allergy products. A single 50 milligram dose in an adult over 65 produces measurable impairment of memory consolidation within 90 minutes, documented in the British Journal of Clinical Pharmacology. After years of nightly use, the cumulative damage to hippocampal cholinergic circuits is not trivial. If you take any OTC sleep product regularly, check the label. If diphenhydramine is listed, that product does not belong in the medicine cabinet of any adult over 60. Number 2, Oxybutynin and Tolterodine, first-generation bladder medications sold as Ditropan and Ditrol. Both are highly lipophilic, meaning they pass through the blood-brain barrier efficiently. A 2012 study in neurourology and urodynamics showed measurable declines in delayed recall after just 6 weeks of Oxybutynin in adults over 65. Newer bladder medications, mirabegron, for instance, do not carry the same anticholinergic profile. If your memory has worsened since starting a bladder medication, that is a conversation to have with your prescriber today. Number 3, Tricyclic antidepressants. Amitriptyline, nortriptyline, doxepin. Still prescribed frequently in low doses for sleep, nerve pain, and migraine prevention. Amitriptyline has one of the highest anticholinergic burden scores of any drug on the market. If you are prescribed it for anything other than a formal psychiatric indication, ask your prescriber specifically whether a lower burden alternative exists for your age group. Number 4, Hydroxyzine, Vistaril, Atarax. Increasingly used as a gentler alternative to Benzodiazepines for anxiety and sleep. It is not gentler on the aging brain. Adults over 65 metabolize hydroxyzine more slowly, meaning it accumulates with repeated dosing. I have patients who were told it was non-habit forming and safe, and who have taken it nightly for 3 years. If this is you, bring it to your doctor's attention before your next dose. Number 5, Benzodiazepines, alprazolam, lorazepam, diazepam, clonazepam. Their mechanism is different, not anticholinergic, but GABAergic suppression of neuronal activity. Long-term use, defined as more than 90 days of daily use, is associated with a 43 to 51% increased risk of dementia in data published in the British Medical Journal in 2014, following over 1,065 patients aged 66 and older. Do not stop abruptly. That is dangerous and requires medical supervision, but this must be on your medication review list. Number 6, proton pump inhibitors, omeprazole, pantoprazole, lansoprazole. Most people take them without a second thought. The mechanism of harm is indirect. PP is reduce, B12 absorption, and long-term B12 deficiency causes progressive myelin degeneration in the brain. A 2016 JAMA neurology study found that long-term PPI use was associated with a 44% increased risk of dementia. If you've taken a PPI daily for more than a year, ask your doctor to check your B12 and methylmalonic acid levels. Number 7. First-generation antihistamines. Chlorpheniramine, promethazine, meclizine. Found in cold medicines, nausea medications, and vertigo treatments. Meclizine is extremely common in adults over 65 for dizziness. All three carry significant anticholinergic burden. The problem, patients don't list them as real medications because they're situational. But 3 times a week in someone with depleted cholinergic reserves is not situational. Alternatives exist. Ask. Number 8. Muscle relaxants, cyclobenzaprine, or phenadrine. Cyclobenzaprine, sold as Flexeril, is structurally similar to tricyclic antidepressants and explicitly listed in the Beers criteria as inappropriate for adults over 65. It is prescribed constantly for back pain and muscle spasms. It's not that the pain isn't real, it's that this specific molecule carries neurological risks that most prescribers don't review at the time of prescription. Physical therapy and non-anticholinergic alternatives exist. Number 9. Oxybutynin Transdermal, the bladder patch. Many patients and some physicians believe the patch form carries less cognitive risk than oral oxybutynin. The data do not support this. Systemic absorption is significant, and the active metabolite crosses the blood-brain barrier. If you wear an oxybutynin patch and your memory has changed since starting it, that patch is a variable that must be reviewed with your prescriber. I want to pause here because there is something important I need to say as a neurogeriatrician. All 9 of these medication categories cause cognitive harm through the same underlying mechanism. They impair the brain's ability to maintain adequate neurotransmitter function in a neurological environment that is already operating with reduced reserve. 9 doors. 1 room. Here is the one thing I want you to take from this video. Your medication list is not static. It was built over years across multiple prescribers for conditions that may have changed. The most valuable thing you can do this week is gather every medication you take, prescription, over-the-counter, and supplement, and bring that complete list to your next appointment. Ask your doctor specifically, can you review my anticholinergic burden? Write that phrase down. Those 4 words can unlock a conversation that changes everything. I've seen adults at 79 recover cognitive function they were told was simply gone. Margaret is not the only one. The brain at 70 still has plasticity. It is never too late. But only if someone asks the right question in time. Which of the 9 medications I mentioned today are you currently taking? Tell me in the comments. I read every one. If you see a pattern in your list, I want to know. If this helped you or someone you love, please share it. There are older adults in your life right now being told their memory loss is just aging while taking Benadryl every night, and nobody has reviewed their medication list in years. And if you haven't subscribed, please do. Everything on this channel exists for one purpose: to give you the neurological information your appointment didn't have time to cover. Everything I shared today is general health information based on current neuroscience and my clinical experience as a neurogeriatrician. It is not a substitute for personalized medical advice from your own doctor or neurologist. Do not stop or change any medication without speaking to your physician first. In older adults, that can be dangerous. Bring this conversation to your next appointment. Your doctor is your partner in this.